Now I will start with this slide. I changed this lecture a little bit compared to the ones that I used to do before. Now if you take the whole skeleton of the body, just recall, you have gone through all these things in your undergraduate period, but just recall that you have two parts in the skeleton, the axial skeleton and the appendicular skeleton. The axial skeleton, consists of mainly the skull and the vertebral column, sternum and the ribs, mainly those three sections. Then to complete, you can actually add, if you want, the hyoid bone and the laryngeal skeleton, which will complete the axial skeleton. But these three things has to be remembered all the time. Then when it comes to the appendicular skeleton or the limb skeleton, you can call it either way, you have two parts actually. The actual skeleton of the limbs, the upper limb and the lower limb, then the girdles, limb girdles, okay, the skeleton of the limbs and the limb girdles. And when it comes to limb girdles, the upper limb is connected to the axial skeleton through the pectoral girdle or the shoulder girdle, and the lower limb is connected through the pelvic girdle. So you have your pectoral girdle here, or the shoulder girdle, and you have your pelvic girdle there. So that is the basic arrangement. So through the girdles, limb girdles, the limb skeleton is connected to the axial skeleton in the center. That is the basic rule. Then if you take a look at the limb skeletons, if you take the upper limb skeleton first, you know that there are different ways in which anatomists, or textbooks on anatomy describe the pelvic and pectoral girdle. Now pelvic girdle, it's one girdle, one circle. You have two hip bones on either side, and one sacrum and coccyx is a very small partner, connecting up and forming one hard circle, which forms the pelvic girdle. And there is extremely little or no relative movement between the two sides. If you take the two hip bones and the sacroiliac joints, it's extremely minimal movement or no movement at all, whatever the way you want to call it. So then when it comes to the pectoral girdle or the shoulder girdle, which consists of the scapula and the clavicle, the two bones only, people describe it in different ways. Some people take all four bones together, the two clavicles and the two scapulae, and call it the pectoral girdle, and they say that it's incomplete here, not like the pelvic girdle. But the issue is the two sides, they are not at all physically connected, and when it comes to function, they function independently of the other side. So all movements and everything are totally separate. So then therefore you can actually take one side as the pectoral girdle, one pectoral girdle, and the other side as another pectoral girdle. So that makes two pectoral girdles. Okay, so that may be easy for you to handle. Sometimes I give the other version also, but you can go by these two pectoral girdles. Okay, so each pectoral girdle, in that definition, each pectoral girdle will consist of scapula and a clavicle, two bones. Then the other important point here is the only anatomical joint that connects the pectoral girdle to the axial skeleton is the sternoclavicular joint here. Sternoclavicular joint there. Even though there is a joint inside the acromioclavicular joint that is within the pectoral girdle between the scapula and the clavicle, only connection between the axial skeleton, physical connection in the sense joint, is at the sternoclavicular joint. Rest of it is totally hung by ligaments and muscles. So that is the important point. So that adds to the mobility of the upper limb. If you compare with the lower limb, the pelvic girdle is totally opposite. The two sides, as I said before, are connected very firmly to each other, and there is hardly any movement, relative movement between the two sides. That is important for weight bearing. Otherwise, if there's relative movement between the two sides, you will not be able to stand on your feet. So it's a difference between the two actually. So this is the point that I highlighted. The only joint, physical joint, is the sternoclavicular joint. Then we will go back and we will go to the next slide and come back. Then if you take the two joints, the only joint, the sternoclavicular joint, that is an atypical synovial joint. And if you take the other joint, the joint that is within the pectoral girdle, which is the acromioclavicular joint, it is also a atypical synovial joint. Both joints, usually these atypical joints, synovial joints, the typical synovial joints, they have hyaline cartilage here at the articular ends of the bone. But in these atypical joints like sternoclavicular and acromioclavicular and even temporomandibular joint, they have a fibrocartilage covering at the articulating ends of the bones. And other than that, there is an articular disc which is also fibrocartilage, separating the joint cavity into two compartments. Now, when it comes to the sternoclavicular joint, in addition, the first costal cartilage is also involved in the joint, other than the manubrium of the sternum and the medial end of the clavicle. So that is an important point to remember. Then there are certain ligaments also here. Okay. Okay, this is the point that I wanted to highlight here. Then coming back to the upper limb skeleton, which is well known to you, just to summarize it, you have this can be called arm or upper arm. Okay, arm or upper arm. Certain authors use the upper arm term. Then that consists of one bone, which is the humerus. Then the forearm has two bones, radius and ulna, radius on the lateral side and ulna on the medial side. Then when it comes to the hand, it has several parts. There at the carpus here, at the carpus, there are 8 carpal bones, 4 bones in each row. There's a proximal row and a distal row, 4 bones in each row. Then you should know the names of the carpal bones. Proximal row you have from lateral to medial, it's scaphoid, lunate, triquetral and pisiform. Then in the distal row from lateral to medial, it is trapezium, trapezoid, capitate and hamate. So that's how you have the 2 rows. Then you have 5 metacarpal bones, and you have 5 digits. 5 digits, and if you take the 5 fingers rather, you can call them digits also, yes. Then if you take the thumb, the first one, it has 2 phalanges. 2 phalanges. Each of the other 4 fingers will have 3 phalanges each. And when it comes to joints, you have intercarpal joints here. Then you have carpometacarpal joints. Then you have metacarpophalangeal joints, and you have interphalangeal joints. And the phalanges also, you can call it proximal phalanx, middle phalanx and distal phalanx when it comes to the other 4 fingers where there are 3 phalanges. So that is the basic arrangement of the skeleton of the upper limb. We went through that slide. Okay, then the shoulder joint complex. This concept of shoulder joint complex is something like this. There are 3 bones in the shoulder joint complex, because why you take it as a complex is that the whole thing is important for the movement of the upper limb. So even though you move the shoulder joint, at certain stage even the scapula is moving with the clavicle. Okay, therefore you have to call it as a complex, otherwise you cannot complete the movements. Then the 3 bones involved in the shoulder joint, the shoulder complex, is the clavicle, scapula and humerus, obvious. Then there are 4 joints involved, the glenohumeral joint or the shoulder joint, which is here, and the acromioclavicular joint, which is this one, and the sternoclavicular joint, which are all the anatomical joints. Then the 4th one is not an anatomical joint, it's a physiological or functional joint, which is called scapulothoracic joint. Scapulothoracic joint, what it means is that you have the scapula here, then you have the posterior surface of the thoracic wall here, and the scapula glides or moves, floats on the thoracic wall, even though there is no physical joint. That is taken as a floating functional joint. So these 4 joints will form the shoulder complex together with the 3 bones. Okay. Then these are all summarizations. Okay. Then if you summarize the muscles that are attached between the axial skeleton and the pectoral girdle, axial skeleton and the pectoral girdle, in front you have the sternocleidomastoid muscle, which is attached between the mastoid process and the medial end of the superior surface of the clavicle. Then you have the subclavius muscle attached to the inferior surface of the clavicle, and the other end is attached to the first rib. Then you have the trapezius. I have not drawn the whole thing, it will cover the whole view. The trapezius attached between the lateral end of the posterior border of the clavicle and the superior border of the spine, and then it is attached to the skull base and the vertebrae here. Okay, it's a long attachment up to the thoracic vertebrae. Then you have other muscles like levator scapulae, rhomboids minor and rhomboids major muscles. Rhomboids minor and rhomboid major muscles. This one is attached to the superior angle, and the rhomboids are attached to the vertebral border. Then now this is drawn with dotted lines and a different color. That is to show you the serratus anterior muscle, because it's attached to the anterior side. You will not be able to see it on this side, even though I have drawn it like this. It's attached to the vertebral border from the anterior, on the anterior surface, and the upper 8 ribs. Upper 8 ribs here, which is supplied by the long thoracic nerve. We will discuss that later. Then the pectoralis minor muscle, again that is on the anterior side, attached from 3, 4, 5 ribs to the coracoid process here, okay, of the scapula. Then you have other muscles now, that is, those are the muscles attached between the axial skeleton and the pectoral girdle. Then there are muscles attached between the axial skeleton and the proximal end of the humerus. Axial skeleton and the proximal end of the humerus. Pectoralis major is one muscle attached between the ribs. There are 2 heads. You have the clavicular head and the sternocostal head. So when it comes to the sternocostal head, that is attached between the proximal end of the humerus and the axial skeleton. Other head is within the upper limb and the pectoral girdle. Then the latissimus dorsi muscle, again it's attached to the proximal end of the humerus. It takes origin from the thoracolumbar fascia and all. Okay. So then there are muscles attached between the pectoral girdle and the humerus. Pectoral girdle and the humerus. Examples are the biceps muscle, biceps brachii muscle, and the triceps brachii muscle. Then you have teres minor and teres major muscles. Okay, minor and major muscles. You have infraspinatus, you have supraspinatus. Then on the anterior side, you have the subscapularis muscle. They are all attached to the proximal end of the humerus. Then covering all these attachments, you have the deltoid muscle, which you can have 3 parts, because it's a fairly large muscle. You have an anterior part, you have a posterior fibers, and you have middle or intermediate fibers of the deltoid muscle. So if you look at the innervation of general pattern of innervation of some of these muscles that I mentioned, there are 2 nerves called subscapular nerves. In fact, there are 3 nerves, but for this discussion we will take only 2. The third one we will discuss later. So there's an upper subscapular nerve and a lower subscapular nerve. The upper subscapular one supplies the subscapularis muscle in the subscapular fossa on the anterior side that I just mentioned. Then the lower subscapular nerve supplies the teres major muscle, and the segments are C5 and C6. Then the suprascapular nerve is another important nerve which supplies the supraspinatus and the infraspinatus muscles above and below the spinous process. Again, the segments are the same, C5 and C6. Then you have the axillary nerve, another important nerve, which supplies the deltoid. And the teres minor muscle, its supply to the deltoid becomes very important later. And again, it's the same segment, C5 and C6. So if you damage C5 and C6, if you damage brachial plexus roots or trunks containing C5 and C6, the upper trunk, you will paralyze all these muscles, all these shoulder muscles that I described that are listed here will be paralyzed. Remember that point, we'll come back to it when we discuss the brachial plexus injuries. Then a few small points before we continue further. The dropped shoulder, the concept of dropped shoulder is due to paralysis of not any of these muscles that I mentioned, due to paralysis of the trapezius muscle, which is a neck muscle. Yes, I described it in the second slide, coming from the neck and the vertebral column here and getting attached to the clavicle and the spine of the scapula here, which will keep the shoulder lifted, you know, in a lifted position. So if that the trapezius is paralyzed due to maybe damage to the accessory nerve, the 11th cranial nerve, which has two roots, the cranial root and the spinal root coming from the spinal cord, cervical spinal cord. If the trapezius is paralyzed, you get dropped shoulder on that side. Then the other condition, winged scapula, that is due to the paralysis of the serratus anterior muscle, I said, attached to the 1 to 8 ribs here and the vertebral border of the scapula here. So when you push against a hard surface like a wall, the vertebral border of the scapula of that side gets lifted up. Okay, that is due to paralysis of the serratus anterior. It can be caused by damage to the long thoracic nerve, which is arising from the brachial plexus roots. We will discuss that. It's maybe it's C5 to C7, I think, if I remember it correctly. Okay, we'll come back to it when we do the brachial plexus. Okay, then attachments on the clavicle. There are many muscles and several ligaments are attached to the clavicle. Someone will have to mute. Okay, now when it comes to attachments on the clavicle, you have a superior surface of the clavicle. You have a superior surface of the clavicle and an inferior surface, which I have drawn here, which I have shown here. This is the superior surface and this is the inferior surface of the clavicle. Then on the medial half, like, you have an anterior surface actually, because it's thick, and a posterior surface. Then laterally, since the bone gets flattened, you can call it an anterior border and a posterior border. It doesn't matter whether you call it surface or border, but remember this point, because the medial end is wider. Okay, and the other point is the inferior, the superior surface is smooth, you know that, and the inferior surface is rough because of the attachment of muscles and important ligaments. Now, when it comes to attachments to the clavicle, on the medial end, the superior surface, the sternocleidomastoid is attached. Clavicular head to the sternocleidomastoid is attached. Then there's a ligament which is called the interclavicular ligament. Between the two clavicles, it is attached. Then to the anterior surface, now the medial 2/3 of the anterior surface is convex to the anterior side. To that area, the pectoralis major muscle is attached. So you can see the attachment in both views. Okay, superior view and inferior view. That's what I have shown here. Okay. Then the deltoid is attached to the lateral end of the bone on the anterior border here. Then the trapezius is attached to the lateral end of the bone on the posterior border. Then between the sternocleidomastoid and the trapezius, enclosing the two muscles, you get the investing layer of deep cervical fascia, which you will learn when you do the neck. So in between the two muscles, it is attached to the smooth superior surface here. Then on the inferior surface, here you have the subclavius muscle attached between the clavicle and the first rib, subclavius. And on the inferior surface, at the medial end, you get the costal clavicular ligament attached between the costal cartilage of the first rib and the inferior surface of the clavicle. Then here laterally, you get an important ligament which is called the coracoclavicular ligament, which has two parts, the conoid part and the trapezoid part. Conoid part and the trapezoid part. It's an important ligament, especially when it comes to the fracture of the clavicle. Then enclosing the subclavius muscle, you have the clavipectoral fascia. Encircling the subclavius, you have the clavipectoral fascia. It continues down. If you have the subclavius like this, you get the clavipectoral fascia enclosing it and moving down to form the suspensory ligament of the axilla, which is attached to the before it gets attached, it has to encircle the pectoralis minor muscle. Okay, encircles the pectoralis minor muscle, and so if the muscle is here, and then forms the suspensory ligament of the axilla, which is attached to the deep fascia of the floor of the axilla here. Okay, and the part of the clavipectoral fascia that encloses the subclavius here fuses with the periosteum. If this is your clavicle, it fuses with the periosteum of the clavicle. Okay, muscle is attached to the bone. The clavipectoral fascia fuses with the periosteum. Then about fractures of the clavicle, depending on the way the force is transmitted, clavicle can fracture at almost any place. There is no issue about it. But the most common site of fracture and the most common reason for fracture is falling on the shoulder or the outstretched hand. You know that. And the most common site, the commoner site for breaks is the junction between the middle third and the lateral third. If you divide the clavicle into three parts, medial, lateral and middle parts, the junction between the middle third and the lateral third, middle third and the lateral third is the commonest site for fracture, and it is usually medial to the attachment of the coracoclavicular ligament. The reason is that if you compare the strength of the ligament and the bone, the ligament is stronger than the bone at that point. So that happens to be the weakest part of the clavicle as well. Okay, so because of that, the strength of the ligament and the weakness of the bone, when the forces are transmitted from the upper limb, this part gets it moves in relation to the middle part, and this fractures here. Okay, so that's what happens. And once the clavicle is fractured, then there is displacement of the medial and lateral fragments. Displacement of the medial and lateral fragments. Now the medial fragment, because of the attachment of the sternocleidomastoid, it pulls the medial fragment up, and the medial fragment is lifted, as you can see here. Then the lateral fragment, the muscle action by the trapezius tends to pull it up, but in the upright position, because of the weight of the upper limb, lateral fragment actually drops. Trapezius is unable to pull it up against the gravity. So the lateral fragment drops. It not only drops because of strong adductors like the pectoralis major and latissimus dorsi on the other side. Okay, latissimus dorsi, the strong adductors, the lateral fragment with the limb is pulled in. Okay, it's pulled in. So ultimately resulting in overlapping of the two fractured ends, and the shortening of the bone. So that is the anatomical reasons why you get this dropping of this one, angulation of that one, and overlapping of the two bone ends. Okay, I think some of you have seen this slide. This slide has been there for some time. Those of you who have not seen this, try to work it out. A patient complained of persistent pain over the side of the neck few weeks after fracture of the ipsilateral clavicle. State the most likely reason. Just think of it, I will show you the answer. Okay, it's due to involvement of the supraclavicular nerves in the callus formed following the fracture. So when the callus is formed, the supraclavicular nerves that are, on the surface of the clavicle can get involved in the callus. So you can get pain. And sometimes, when the bone is formed, actually some of the supraclavicular nerves actually can come through the clavicle. Okay, can come through the clavicle. So then the chances would be higher, when there is entrapment of nerves after formation of callus. Concept of rotator cuff muscles. Of the muscles that we described, which are attached between the scapula and the proximal end of the humerus, 4 short muscles are called rotator cuff muscles. The subscapularis, supraspinatus, infraspinatus, and teres minor muscles. So teres major, deltoid, they are not included. Even subscapularis, they are deltoid and teres major are not considered as rotator cuff muscles. Other 4 are considered rotator cuff muscles. Now the significance of these muscles is that they have short flat tendons which are attached to the shoulder joint capsule all around, strengthening the capsule except on the inferior side. All around the capsule is strengthened anteriorly, posteriorly, and above, and at the same time the short tendons are attached to the lateral or anterolateral or posterolateral surfaces, or superior lateral surface of the humerus. Because of that, they become the most important stabilizing factor of the shoulder joint. Only thing is, at least anatomically, we can say that inferiorly there is a weak area which allows inferior dislocation. But it's not always, it's the inferior dislocation that happens. If you ask from orthopedic surgeons, they would say that it might not always come down and go up. It might directly go like that. Okay, damaging the anterior side of the glenoid labrum. Okay, so that's a different thing. You can read articles. If you type in the internet, you will be able to find articles on this. So you can actually see in this diagram, you can see the rotator cuff muscles. You have the supraspinatus here, you have the infraspinatus, you have teres minor, and the subscapularis muscles, which are very closely associated with the joint above, behind, and in front. So there is a weakness of rotator cuff here, but still you have the triceps. If you abduct, you have the triceps long head coming here, which is attached to the infraglenoid tubercle. You remember the glenoid cavity of the scapula. You have supraglenoid tubercle and infraglenoid tubercle. Long head of triceps is attached here. Long head of biceps is attached there. So when the humerus is abducted, this comes and actually protects the inferior side, the triceps long head. But still, it can dislocate in that position. Then, as I said before, the stabilizing factors, the most important stabilizing factor is the rotator cuff, the muscles that I just listed out. Then other than that, another important stabilizing factor for which prevents superior dislocation of the humerus is the coracoacromial arch formed between the coracoid process of the scapula and the acromion of the scapula and the coracoacromial ligament, which is attached between the two bony points, coracoid process and the acromion. It's all within the scapula itself. Okay, so then that prevents superior dislocation of the humerus. Then you have glenohumeral ligaments. There are several of them. Then you have the glenoid labrum, you know, this is the glenoid fossa of the bone, and then it is strengthened by a fibrocartilage rim, which is called the glenoid labrum, which slightly deepens the glenoid cavity. Then, as I said before, you have the long head of biceps above and the long head of triceps also you can add here, okay, below. And the long head of biceps, it actually goes through a groove here between the lesser tubercle and the greater tubercle, which is called the intertubercular groove or the bicipital groove, and then it is attached to the supraglenoid tubercle there. So that also is important to prevent dislocation. Then when it comes to actual dislocation, about 95% of the dislocations are anterior dislocations. This is what I said, anatomically we say that it inferior dislocates and pulled up by the action of muscles, so that ultimately it lies immediately below the coracoid process in a subcoracoid position. I don't know whether I have, inferior to the coracoid process in a subcoracoid position. So you will actually lose this hollow area here. If you touch, you will feel the head in that area below the clavicle, the subcoracoid place. And whether it dislocates this way and moves up this way or directly dislocates, ultimately it lies on the anterior to the glenoid fossa. That's why you call it anterior dislocation. And with this dislocation, because of the movement downwards, if it happens that way, it is possible to damage the axillary nerve, because your humerus, the head is like this. Humerus, axillary nerve passes in relation to the posterior surface of the surgical neck here. When the bone moves down, the nerve can get trapped here and can get damaged. So axillary nerve damage is a risk. So in shoulder dislocation, as you can see here in the X-ray, the head lies below the coracoid process here, subcoracoid position, and the glenoid cavity is empty. Therefore, you lose the nice rounded contour of the shoulder joint, which is there because of the head of the humerus lying here and the deltoid passing over that area. So now the head is not there anymore. So you get this the contour, rounded contour lost on the affected side. So what happens with the axillary nerve, I think we will have a chance to discuss it later. Okay, not now. I think with the surgical neck fractures we will discuss it. Then the painful arc of the shoulder joint, different textbooks give different ranges. Now this is from Snell's clinical anatomy book. It's from roughly 50 to 130. Some authors give it as 60 to 120, slightly less, 10 less from each side. Okay, so whatever it is, what you need to remember is that the middle range of abduction. Okay, not the initial part of abduction or the latter part of abduction. It is the middle part of abduction, whether it's 50 to 130 or 60 to 120. The idea is that. And the painful arc occurs due to either subacromial bursitis, supraspinal tendinitis, or pericapsular pericapsulitis. Now, you know what is supraspinatus tendinitis? It's the inflammation of the tendon of the supraspinatus muscle, either due to small tears or overuse of the muscle. Then you have the subacromial bursa here between the coracoacromial arch and the superior surface of the supraspinatus muscle. So if you get bursitis there, again you get the same condition. I think there's a picture. So this is your subacromial bursa. So bursitis, in that again you can get the painful arc. Then other than that, you get this pericapsulitis is, I think, same as your frozen shoulder. Okay, I think it's a vague, it's an umbrella term. I think this frozen shoulder. So there actually what you get is perivasculitis. That's what I understood when I read it. So you just read around pericapsulitis if you want. So that is another reason for painful arc. Okay, because whatever it is, when these structures that are inflamed, when they impinge on the acromion here, when you abduct the limb, you get little limitation of space here, then you get the pain. Okay, that's why you get it in the middle part. Once they move inside, again the pain becomes less, because in the latter part anyway it's not the joint moves, it's the pectoral girdle that moves. Okay, so you don't have much pain at that part. Then we will go through some of the fractures of the humerus. Now you can get avulsion fractures of the greater tuberosity here. Avulsion fractures of the greater tuberosity due to violent contraction of the it says sometimes it's the rotator cuff muscles, but it's mainly the supraspinatus. Okay, some people just call it the rotator cuff muscle violent contraction when you fall on the outstretched upper extremity. That's what they say. Okay, so that is anyway due to violent contraction of these short muscles which are attached to the greater tubercle. And you should know that these muscles are attached to the greater tubercle, supraspinatus, infraspinatus, and teres minor. So all their attachments will be gone, and what will happen is you will have this medial rotation, because this the lateral rotation is gone, and your initiation of abduction will be lost. The first 15 degrees of abduction is initiated by the supraspinatus, so that will be gone. So those are the things that will happen with this avulsion fracture. Then the surgical neck fractures, most of the upper limb fractures are due to falling on the outstretched hand, you know that. Then surgical neck fractures, you can get damage to the posterior circumflex humeral artery or the axillary nerve, which are both related to that area posteriorly. Then when the axillary nerve is damaged, the two muscles supplied by the axillary nerve, the deltoid muscle and the teres minor muscle, will be paralyzed. And there is loss of abduction above 15 degrees. Because the first 15 degrees, it's supraspinatus that does the abduction. Then after that, it is the deltoid, the middle fibers of deltoid that does it. So that is gone. Then okay, flexion, extension, rotation can be weak because deltoid, the three parts of the deltoid muscle contributes to do those things. Then most importantly, you get, if your deltoid is like this, and the skin over the deltoid, if you take like this, okay, the skin over the lower half of the deltoid is supplied by the axillary nerve here, okay. So that will be gone. So you will get anesthesia of the skin over the lower half of the deltoid. Now over the upper half of the deltoid, which is the tip of the shoulder, that area, it is supplied by the supraclavicular nerves by C4 segment. Okay, so here it's axillary nerve by C5 segment. Okay. Then when it comes to fractures of the shaft is fairly long area, so you can have fractures, upper fractures and middle fractures, or even little lower level fractures. You have at this level you call it supracondylar fractures. So shaft can fracture at different places, but all places might not be important. But if you take fracture happening proximal to the attachment of the deltoid, proximal to the deltoid tuberosity, and a fracture happening distal to the deltoid tuberosity through the radial groove. We will discuss those two. Now the proximal to deltoid insertion, when the bone fractures, what will happen to the two fragments? The anatomical explanation is that the proximal fragment is pulled in by the action of the deltoid, the pectoralis major muscle, as you can see here. And the distal fragment is pulled up by the action of biceps and triceps muscles. Ultimately, there is shortening of the bone here. Okay. Then, if the fracture line is distal to the deltoid insertion, as in this case, then even though the pec major pulls that way, now the deltoid will pull in that direction. Ultimately, what will happen is there is abduction of the shoulder joint, abduction of the proximal fragment. Okay, then fractures distal to the deltoid insertion. So the proximal fragment is abducted by the deltoid muscle. The distal fragment is again, the same thing. Distal fragment is pulled up by the biceps and triceps. So again, there can be shortening in that way. So if you look at an X-ray, actually, you can work this out. Then damage to the radial nerve in a mid-shaft fracture, damage to the radial nerve in the radial groove, you will get wrist drop. You will get wrist drop because all the extensor muscles of the fingers and the wrist are gone, because it's the deep branch of the radial nerve, and before the deep branch is given, some muscles are supplied by the radial nerve in that area, so that is all gone. So you get wrist drop, and there's loss of extension and reduced abduction of the thumb. So loss of extension and reduced abduction of the thumb is due to the loss of extensor muscles. You know that when you take the thumb extension is done by extensor pollicis, brevis and longus. They are gone. They are not supplied when the nerve is damaged. And the reduced abduction, in the sense you get when you get the thumb, you get two abductors, abductor pollicis, brevis and longus. Longus is supplied by the branches of the radial nerve. Brevis is supplied by branches of the median nerve. So that's why I said reduced abduction of the thumb. This is all, anatomical theoretical explanations. Okay. Then you can get some weakness in the supination. Why? You have two main muscles, supinators, biceps and the supinator itself. Now the supinator is paralyzed. Therefore you expect some weakness in supination, even though the biceps is the main supinator. Okay. Then anesthesia over the back of the forearm and hand. Because the radial nerve branch just supply the skin of the back of the forearm and the hand to some extent, even though there are overlaps. Okay. So the important point here is that even though you get wrist drop and paralysis of forearm extensors, the triceps is not totally paralyzed, because triceps is supplied by, yes, you can see here you get certain branches, high branches in the axilla coming from the radial nerve that supplies the triceps. Therefore, if you damage the nerve at that level, you will not get triceps totally paralyzed. Okay. Supracondylar fractures. Now there are two types of supracondylar fractures. So if you have the humerus like this, you have the two condyles, medial and lateral condyles. Then you have your trochlea and capitulum here. So fracture line passes through the medial and lateral supracondylar ridges, and depending on the type of fracture, you have an extension type and a flexion type. Extension type is the more common type, which is about in 95% of the cases you get the extension type. That is due to an injury like this, falling on the outstretched hand with the elbow slightly flexed, like this. Okay, so the force is transmitted like that, and the distal fragment of the humerus that is broken is pushed backwards and angulated backwards. So you can see that it's displaced backwards and angulated backwards. Okay, so this angulated backwards and pushed backwards. Then the other type of injury is flexion type, that is due to falling on the flexed elbow. Okay, so if the force is given in that direction, if this is the flow, then the distal fragment of the humerus fractured will be pushed forwards. So you can see it here. Okay, so that is flexion type, which is not very common. Whatever it is, when you get supracondylar fractures, you actually do not lose the relationship between the three bony points at the elbow, the relationship between the lateral epicondyle, medial epicondyle and the olecranon of the ulna. But this relationship is disturbed if you dislocate the elbow joint. So if this part is dislocated, so this relationship will change. Okay, the the triangular relationship between the three bony points. That's how you differentiate between supracondylar fractures and elbow dislocation if there is no X-ray available. Again, it's common in children falling on the outstretched hand. So with the supracondylar fractures, it's not only median nerve, it may be the more common nerve to get injured, but even the radial nerve or the ulnar nerve can get damaged because of this angulation and the ragged edges of the bone. And you can get either damage or obstruction of the brachial artery. So what they say is, if you have damaged the wall of the brachial artery, you can get formation of thrombi there and embolization of that will block the distal parts of the artery. Depending on the size of the block, you can either block the whole artery or radial, ulnar, or the common necrosis or introsis arteries. So depending on the block, you can get ischemia of different muscles. Then the other thing is, due to tissue damage in that area, you can get compartment syndrome. Okay, and that also can obstruct the blood vessels, the brachial artery and its branches. So either way, whether it's this or that, you can get Walkman's ischemic contracture. Okay, either due to compartment syndrome or just obstruction of the artery after minor or major damage to the artery. So Walkman's ischemic contracture, even though this is the typical picture of Walkman's ischemic contracture, which is actually flexion of the wrist joint and full claw hand. It's a full claw hand. You have heard about ulnar claw hand, and this is full claw hand. All fingers are clawed. But this typical picture is there only if there is ischemia and necrosis and fibrosis of both flexors and extensors to the same degree. Okay, so that means you block the whole brachial artery, or you block both all three arteries, branches of the two brachial arteries and the common introsis. If you block all the vessels to the extensors and flexors, then you will get this typical picture. So what is the typical picture? You get flexion of the wrist joint, flexion of the interphalangeal joints, extension of the metacarpophalangeal joints. Okay, so this interphalangeal flexion, wrist flexion, and metacarpophalangeal extension. Now the anatomical explanation is that the flexor muscles are much stronger and bulkier than the extensor muscles. Okay, flexor muscles here are much bulkier and stronger than the extensor muscles. So if both sides are equally fibrosed, then the strength is far on the anterior side, the fibrosis strength. That will flex the wrist joint as well as the interphalangeal joints. Extensors can only, what they do is, the fibrosed extensors will only extend the metacarpophalangeal joints. Okay, then you get this claw appearance plus the flexion of the wrist. But depending on the degree of damage to the vessel, say you get thromboembolization after injury, and which only obstructs either radial artery or ulnar artery or common introsis artery, then you might not get this equal similar fibrosis of both sides. Then depending on that, you might get different picture. You might not get this typical picture, or don't always expect to get that picture in ischemic contracture. Okay, can have variations. Then okay, we will okay, the compartment syndrome, the same thing. Now why you get compartment syndrome in limbs? The reason is that they are enclosed by tough, deep fascia around, and inside usually there are intermuscular septa separating the compartment, separating the that part of the limb into compartments: anterior compartment, posterior compartment, lateral compartment, like that. And again, you have superficial and deep compartments. Then all these, and you have the interosseous membranes also between the two bones when it comes to the forearm and the leg. So these interosseous membranes and the intermuscular septa, they actually blend with the periosteum of the bone. Okay, so you cannot separate them out unless you tear them off. Okay, so they blend with the periosteum of the bone here, and if it is an intermuscular septum, it again blends with the deep fascia here. Okay, so you have the bone here, you have the deep fascia here, intermuscular septa connecting the periosteum of the bone to the deep fascia here. So it's a very tight compartment system that you get. Inside that you get muscles, nerves, arteries, and deep veins, all that. So when the pressure increases in the compartment, you can initially obstruct the vessels, veins first, then arteries, and then the nerves if it continues. So the vessel obstruction, arterial obstruction is crucial. You get ischemic necrosis of muscles. Okay, so what you do is you release the pressure of the compartments by opening up the fascial compartments. Now, how do you suspect compartment syndrome is that the pain is disproportionate to the injury. Pain is disproportionate to the injury. So that is one important point. Okay, if there is unexpected high degree of pain, then you suspect compartment syndrome. Then again there is pain on passive stretching of muscles. So if you try to extend the fingers, then you will get pain in the forearm muscles if there is forearm compartment syndrome like that. Okay, then there is absence of capillary filling and skin tenderness. Okay, so skin would be tender to touch. Okay, these are all signs of lack of blood supply. Then the fractures of the distal end of the forearm bones. Distal end of the forearm bones. The Colles fracture. Now, Colles fracture, you know about these things. You have worked in boards. You know this better than myself, I think. Okay, anyway, I will go through it. So it can be either radius and ulna both, or only radius fracture. So still you call it Colles fracture, and common in people over 50 years, whether it's male or female. Then it's again falling on the outstretched hand, and again when you fall in the outstretched hand, force is in that direction, so you get displacement and angulation of the distal fragment posteriorly. Okay, and if you get the patient to keep the forearm and this one I am referring to, keep the forearm and the palm on the surface of a table, you get this typical dinner fork deformity. Okay, typical dinner fork deformity, as you can see here. Okay, so the reverse Colles fracture, if you fall on the back of the forearm, if you fall on the dorsum of the forearm, not on the palm, you get the reverse Colles fracture because of the forces applied in the opposite direction. So you get displacement of the fractured the distal fragment anteriorly. Okay, so this is the anterior side. It's displaced anteriorly. Okay. Then the scaphoid fractures, again it can be due to falling on the outstretched hand. When the scaphoid is fractured, since it forms it's one bone that forms the floor of the anatomical snuff box. You know what is anatomical snuff box, which is here. It forms the floor of the anatomical snuff box with 3 other bones. So you can, if you press the anatomical snuff box, you get tenderness there. Okay, anatomical snuff box tenderness. Now the issue with the scaphoid fracture is that its blood supply comes from the distal end. Blood supply comes from the distal end. You can have branches entering even little proximally like that. So it can fracture in the middle, more closer to the distal end, or the proximal end. It can fracture at any place, but because there are variations in blood supply, even though the blood supply is from the distal end, again there can be variations from where actually the blood vessels are entering. So if you fracture somewhere here, because the issue is with the proximal fragment. Okay, if you fracture somewhere here, as you can see here, since there are certain blood vessels still entering, this fragment will be okay. Okay, then if you fracture in the middle or close to the proximal end, then the proximal fragment is at very high risk of avascular necrosis. So the more proximal the fracture line is, the higher the risk of avascular necrosis of the proximal fragment. Okay, remember it's the proximal fragment that is at risk. Blood supply comes from the distal fragment and this fragment would be okay. Okay, when the fracture line moves distally, the risk of avascular necrosis of the proximal fragment becomes less and less. So I think you can understand it. Then few things about superficial veins that we did not discuss so far. Now there are two types of superficial veins. You have the cephalic vein. You have the cephalic vein and the basilic vein that starts from the dorsal venous arch here. You have a dorsal venous arch here. Cephalic vein starts from the lateral or the radial end of the dorsal venous arch. Basilic vein starts from the medial or the ulnar end of the dorsal venous arch. Cephalic vein runs on the radial border or the preaxial border of the forearm and it runs along the arm, passes through the deltopectoral groove and pierces clavipectoral fascia in that area, and just outside the outer border of the first rib it enters the axillary vein, and then at the same point actually the axillary vein becomes the subclavian vein at the outer border of the first rib. So that's how the cephalic vein passes. The basilic vein runs on the medial border of the forearm, enters the arm here and pierces the deep fascia of the arm above the elbow joint, and it joins brachial vena comitatus and forms the axillary vein at the lower border of the teres major muscle. So you get the basilic vein going in, brachial vena comitatus are coming, and you forms the axillary vein at that point. Okay. So then you have this median cubital vein, which is clinically important vein connecting up the cephalic and the basilic veins in front of the cubital fossa here, and yes, okay, and the deep veins, are arranged as vena comitatus of arteries. So you have ulnar vena comitatus, radial vena comitatus, and brachial vena comitatus. Okay, brachial vena comitatus. So here you can see the basilic vein entering the brachial vena comitatus and forming the axillary vein here. Axillary vein roughly at the lower border of the teres major muscle, and the axillary vein becomes the cephalic vein opens into the axillary vein closer to the outer border of the first rib here, and then the axillary vein becomes subclavian vein at the outer border of the first rib. Okay. And there are connections between superficial veins and deep veins. So this is an example of connections between superficial and deep veins. There's a vein called deep median vein, which pierces the roof of the cubital fossa here and drains the median cubital vein to the brachial vena comitatus at that point. Okay, so remember that there are connections between superficial and deep veins, not only in the lower limb, even in the upper limb you have connections. Okay. Okay, now try to answer this question. Okay, I'll show you the answer with reasons. Okay, so these are the answers. It runs upward, the median cubital vein runs upwards and medially from cephalic to basilic, which is true. So you have your cephalic, you have your basilic, median cubital vein runs like this usually. And it lies deep to the bicipital aponeurosis. No, it's superficial to bicipital aponeurosis. It is used for cardiac catheterization, yes. An anomalous ulnar artery lies superficial to it. No, artery is not superficial. Artery is anyway deep to the vein, but the artery can be superficial to the aponeurosis. So that is the point actually there. So then intravenous injections to it run high risk of arterial puncture in high bifurcation of brachial artery. Now, which is true because an anomalous superficial artery, anomalous superficial ulnar artery can be associated with high bifurcation of the brachial artery. Now, actually I read about this yesterday and I found an article. I'll show you. Now these are the variations. I just added it to this lecture, which could be interesting. Now just try to read this. Variations of the brachial artery, and the corresponding incidences as they are represented in literature. Actually, there were some references here. I removed them. There was certain literature. So this is based on actual evidence. Okay. Now these are the variations of the brachial artery that you can get. Superficial brachial artery. You can see the percentage here. Then high bifurcation of the brachial artery. Okay. Then high origin of radial artery. Okay, what it means is that you get the brachial artery coming, you get a radial artery given up at a higher level, brachial artery comes down and divides into common introsis artery and the ulnar artery. Okay, so then this that is far the commonest variation, it seems. High origin of radial artery, which is about 15%. Then high origin of ulnar artery. There, ulnar artery is it takes origin early. Then the brachial artery comes down and divides into common introsis and radial arteries. Okay, so that is less common. Then high division of the superficial brachial artery. Okay, so you can have a brachial artery very superficial, and then that can divide into radial and ulnar arteries at a higher level, which is the least common one. Okay, so if someone asks the commonest form of variation in the brachial artery, it is the high origin of the radial artery. Okay, so here it was the superficial ulnar artery in high bifurcation of the brachial artery. So high bifurcation of the brachial artery is this one. Okay, high bifurcation of the brachial artery is that one. Okay, it need not be superficial. High bifurcation, so that can be associated with superficial ulnar artery. Okay, but I could not find that part. I was trying to find the superficial ulnar artery and details about it. You can just read it in the internet. Okay, you will be able to find. Nowadays, when you type these things, you get research articles rather than just textbooks. Okay, so you can get very accurate information. Then, okay, this is a question on cutaneous nerves. Just try to answer it, just to break the monotonous lecture. Regarding cutaneous nerves of the upper limb. Okay, I will show you the answers. Okay, so these are the answers. Upper lateral cutaneous nerve of the arm supplies skin over the upper half of the deltoid. Now this upper or superior lateral cutaneous nerve of the arm is the cutaneous branch of the axillary nerve. We discussed it already. Axillary nerve. So we said if you take the deltoid, I think I have drawn it already. This is your deltoid, and if this is your skin over the deltoid, the lower half, the skin over the lower half of the deltoid is supplied by the axillary nerve through the upper lateral cutaneous nerve of the arm. So it is not the upper half, skin over the upper half. That's why it's wrong. So that half is supplied by C4, supraclavicular nerves. Okay. Then lower lateral cutaneous nerve of the arm is a branch. No, it's the upper lateral cutaneous. There is the branch of the axillary nerve. Lower lateral cutaneous is a branch of the radial nerve. Okay, it's not the axillary nerve. Okay. So it supplies actually skin below the deltoid muscle. Intercostal brachial nerve supplies second thoracic, carries second thoracic segment. Yes, intercostal brachial is the T2 segment carrying nerve. Then lateral cutaneous nerve of the forearm is a branch of the radial nerve. No, lateral cutaneous nerve of the forearm is a branch of the musculocutaneous nerve, the nerve of the anterior compartment of the arm. Okay, medial cutaneous nerve of the arm is a branch of the medial cutaneous of the arm and forearm are direct branches from the medial cord of the brachial plexus. They are direct branches from the medial cord of the brachial plexus. Okay, few things about superficial nerves because of that MCQ. Intercostal brachial supplies axilla with T2. It's the second intercostal nerve. It's a branch of the second intercostal nerve. Sorry. Then superior or upper lateral cutaneous nerve of the arm is from the axillary nerve. I think I mentioned this in the previous slide. Then the lateral cutaneous nerve of the forearm is from the musculocutaneous nerve, which comes out lateral to the biceps tendon in the cubital fossa. Cubital fossa, we'll see that in a moment. Then the superficial branch of the radial and dorsal branch of ulnar nerves. Now the superficial branch of the radial, now if this is your elbow, joint area, the radial nerve comes from behind. Radial nerve comes from through the behind the related to the radial groove and comes to the anterior side here and divides into superficial and a deep branch. Okay, so superficial branch of the radial nerve actually supplies the skin over the dorsum of the hand. The skin on the lateral side of the forearm is actually supplied by the lateral cutaneous nerve, which is a branch of the musculocutaneous nerve. So here it is the superficial branch of the radial nerve. Then the ulnar nerve also gives the posterior branch, which is called the dorsal branch or the posterior branch of the ulnar nerve, which supplies the dorsum of the hand on the ulnar side. Okay. So with that, we will discuss some of the cutaneous nerves, the important ones. We will see them in this diagram rather. So your upper lateral cutaneous nerve of the arm is this one, which is the branch of the axillary nerve, which supplies the lower half of the skin over the lower half of the deltoid, which is affected in axillary nerve damage. Then the skin over the upper half of the deltoid, as I said before, is supplied by the supraclavicular nerves, which are branches from the cervical plexus. They are branches from the cervical plexus. With C4, it is supplied. This is C5. Then the intercostal brachial nerve, a branch of the second intercostal nerve. This is T2. Okay. Then the lower lateral cutaneous nerve of the arm, which is a branch of the radial nerve, that also will carry C5, I think. C5, and this lateral cutaneous nerve of the forearm, which is from the musculocutaneous nerve, it will carry C6 in that area. No? Yes, C6. Okay. Then the superficial branch of the radial nerve, as I said, will supply the dorsum of the skin. Here, superficial branch of the radial nerve, that area. And this is the posterior cutaneous branch or the dorsal branch of the ulnar nerve, which supplies the ulnar side. Okay. Okay, those are the important ones actually. Okay. Then the other important thing is the palmar-cutaneous branch. Palmar-cutaneous branch of the median nerve, which actually bypasses, it doesn't bypass, it goes superficial to the carpal tunnel here and supplies the skin over the tena eminence here on the palm. Okay, which is an important branch in carpal tunnel syndrome at least. Then a few more things about the dermatomes. Now if you check the dermatomes on the anterior chest wall, you will see that at sternal angle, manubriosternal angle or angle of Lewis, you see an abrupt change from T2 to C4. Okay, T2 to C4. So if you are looking for a sensory level in a neurological examination, if you go up from here, you should remember that at the sternal angle, you will jump from T2 to C4. So you would rather go along the medial aspect of the upper limb, along the hand, and then come along the lateral aspect of the upper limb and come back to the neck, like that, rather than going directly into the neck, because of the formation of brachial plexus and because of the fact that the brachial plexus is totally taken into the upper limb, you get C5 to T1 missing on the anterior thoracic wall here. Okay, so that is the point that I wanted to raise here. If you look for sensory levels, you have to remember this. Then there's another point. If you look at the hand, the palm side, palm and the dorsum of the hand, the typical description is that the middle finger is C7. Dermatomes, I am referring to the dermatomes. Middle finger is C7, then medial to that it's C8, and lateral to that it's C6. So your index finger and thumb are supplied by C6 dermatome. Your little finger and maybe part toes, the full ring finger, is supplied by the C8 segments. So it's true for anterior and posterior sides, or the palmar and dorsal sides both. But if you overlap this, or if you in parallel, if you consider the nerve supply of the palm and the dorsum of the hand, you can see that on the palm side, if you first take the palm, the median nerve supplies the lateral 3.5 fingers. Lateral 3.5 fingers supplied by the median nerve. Then the medial 1.5 fingers is supplied by the ulnar nerve. Then on the dorsal side, the lateral half, more than half, maybe 3.5 side, is supplied by the radial nerve and partly the median nerve. Then the ulnar side is supplied by the ulnar nerve again. Okay, so if you overlap the two diagrams together, what you can understand is that the C7 is brought in here by median nerve. Okay, C8 is brought in by ulnar nerve. Okay, and C6 is brought in by median and radial nerves. C6 is brought in by median and radial nerves. And now radial nerve might bring C7 also. Okay, because radial nerve supplies that area. Okay, C6 and C7 by radial nerve, and median nerve. C8 is mainly by ulnar nerve. So remember that point as well. Not only dermatomes, remember the nerves also that brings them in. Okay, coming back to the brachial plexus. We already know that it is from C5 to T1 spinal, the anterior primary rami of spinal nerves. If you have forgotten about anterior primary rami, so this is how it happens. You have the spinal cord section like this. If you draw it like this, central canal, you have the posterior nerve root coming in like this. You have an anterior nerve root coming in going out actually like that. You have the dorsal root ganglion here, and these two join, anterior and posterior nerve roots. These are the real roots. Okay, and they join, and roughly, anatomically, this is the intervertebral foramen area. Okay, so you have vertebral above and vertebra below, and this is formed by the by the arches of the vertebral arches. So the nerve that is formed here is called the spinal nerve. Okay, spinal nerve, this is a mixed nerve. It is a mixed nerve because you have sensory here, you have motor here, then it's not only sensory and motor, you have somatic and you have autonomic as well. Okay, so all four types are there: sensory, motor, autonomic and somatic. So then this spinal nerve divides into a posterior branch and an anterior branch. So this is called anterior ramus, so anterior primary ramus, and a posterior primary ramus. Anterior primary ramus is much larger than the posterior primary ramus. Posterior one supplies only a strip of skin at the back with some vertebral muscles at the back muscles actually. It is the anterior primary rami of the spinal nerves that actually supply the limbs and the trunk mainly. And they are the ones, the anterior primary rami are the ones that contribute to form all your plexus, whether it's cervical plexus, brachial plexus, lumbar plexus, sacral plexus or coccygeal plexus. It is all anterior primary rami that contribute to form. Okay, so when we talk about the brachial plexus, you have to remember that when we say the roots of brachial plexus, you know the roots are written like this, brachial plexus within inverted commas, because these roots are actually not the true roots, but they are the anterior primary rami of the spinal nerves. Okay, anterior primary rami of spinal nerves. Here we call them roots because they are the beginning of the brachial plexus. Okay, from the point of view of brachial plexus, they become roots. Okay, so you have roots from C5 to T1, and the upper two roots they unite and form the upper trunk. Okay, they form the upper trunk. Then the lower two roots unite and form the lower trunk, upper trunk, lower trunk. Then the C7 middle one continues as the middle trunk. Then each trunk is divided into an anterior and a posterior division. All posterior divisions of all three trunks unite and form the posterior cord. The anterior divisions of upper and middle trunks unite and form the lateral cord. The anterior division of lower trunk continues as the medial cord. Now the lateral, medial and posterior cords are named based on their relationship to the axillary artery in this area. Axillary artery in that area. So one that is lateral to it called lateral and so on. Okay. Then from the cords, lateral, medial and posterior cords, you get branches which are important for us. From the lateral cord, you get 3 branches. From the posterior cord, you get 5 branches. From the medial cord, you get another 5 branches. Okay, that's how it happens. So we will take a look at some of these branches. Now before that, now the typical description of the brachial plexus is that its roots lie between the anterior and middle scalene muscles, scalenus anterior and scalenus medius muscles. So that is in that area. Scalene muscles are in that area. Then the trunks lie in the posterior triangle, and the divisions lie behind the clavicle. So if you draw your clavicle would be like this. Okay. So the clavicle, the divisions lie behind the clavicle. Then the cords lie in the axilla. So this is the area of the axilla. Cords lie in the axilla. And when it comes to the relationship between the cords and the axillary artery, now the axillary artery we will discuss in a moment. It has 3 parts. It has a first part, second part and a third part. So the typical description is that the cords of brachial plexus approach the first part, embrace the second part and gives branches in the third part. Okay, so that's basically how it is described. Okay, and they are named according to the relationship to the artery. Okay, the same thing. I had a different diagram here. The same thing. Okay, so you can see it better in this diagram. You have the axillary artery here. So you see the lateral cord here, posterior cord and the medial cord. and the axillary vein lying further medial to the axillary artery. That's a different issue. Then if you look at the branches that you get from brachial plexus before the cords are formed, certain branches are given. Now I said when it comes to branches from cords, you get 3, 5, 5 from the cords. But there are branches given before the cords are formed. Now this is how it happens. You get a nerve arising from the first nerve root, C5 nerve root here, which is called the dorsal scapular nerve. Dorsal scapular nerve, therefore it carries C5 and it supplies the rhomboid muscles, rhomboid major and minor muscles. Then you have another nerve arising from C5 and C6, both roots, which is the nerve to subclavius muscle, which is this one. Then you get the long thoracic nerve starting from C6, 7 and T1, C8, C5 to C5, sorry, it's C5, 6, 7. Okay, C5, 6, 7. It is the long thoracic nerve, which is this one, long thoracic nerve, which is the nerve that supplies the serratus anterior muscle. And when you damage this nerve, you get the winged scapula due to paralysis of the serratus anterior muscle. Then from the upper trunk, you get one nerve. This is the nerve, upper trunk. It is the suprascapular nerve that supplies the supraspinatus muscle and the infraspinatus muscle with C5 and C6. Okay, C5 and C6. Okay, it's upper trunk. Okay, these are the actual branches that you get from different cords, which I need not go into details of, I think. From the lateral cord, first branch is the lateral pectoral nerve. Then you get the musculocutaneous nerve, which is an important nerve, one of the 4 main nerves that supply the upper limb. Then you get the lateral root of the median nerve. Those are the 3 branches. Then from the medial cord, again the first branch is the medial pectoral nerve. Then you get medial cutaneous nerve of the arm and the medial cutaneous nerve of the forearm. Then the ulna, the last branch, is the medial root of the median nerve. Okay. Then from the posterior cord, you get 3 subscapular nerves, upper, lower and middle subscapular nerves. Middle subscapular nerve is called the thoracodorsal nerve. Okay, so that makes 3 branches. Then you get the axillary nerve and then continues as the radial nerve. That makes it 4. Okay, it's very easy to remember the branches if you remember it that way. Okay. So then few more things about the posterior cord. Yeah, I think I have listed this out. Now, if you look at the posterior cord here, just to show you the posterior cord, this is your posterior cord. Now, I said there are 3 subscapular nerves, upper subscapular, middle subscapular and lower subscapular. Now, the middle subscapular one, it happens to be the longer one. As you can see here, it's the longer one. So, you can either call it middle subscapular or long subscapular nerves. Different terms are used by different people, but the more acceptable term is the thoracodorsal nerve. Okay, which is the nerve that supplies the latissimus dorsi muscle. Latissimus dorsi muscle. So these will make 3 branches from the posterior cord. Then you get the axillary nerve and the radial nerve. Okay, it's easy. Then another important point, if somebody asks you the segments carried by the 4 main nerves that supply the upper limb. The 4 main nerves that supply the upper limb are the musculocutaneous nerve, this one, ulnar nerve, radial nerve and the median nerve. Okay, now this is how you remember it. It's very easy. Radial nerve and the median nerve, which has a considerable distribution, they carry all the segments C5 to T1. Okay, all segments are carried by radial nerve and the median nerve. All segments are carried by the radial nerve and the median nerve. When it comes to musculocutaneous nerve, it carries the first 3 segments C5, C6 and C7. When it comes to the ulnar nerve, it carries the last 3 segments C7, C8 and T1. It's very easy to remember. Okay. radial nerve and ulnar nerve, all segments. Musculocutaneous nerve, first 3. Ulnar nerve, last 3 segments. Now, certain books omit this one. No, they omit, I think, C7. Only leaving C8 and T1. But I checked Grace, it includes C7 as well. Okay. It's better to include C7. It's easy to remember also that way. Okay. So if you get an MCQ, be a little bit careful, because some MCQs can be formed by some textbook, and then you might only have C8 and T1 sometimes. Okay, it's possible. Okay, but remember, this is very easy to remember. Okay, and the other point is the median nerve has no branches in the arm, or you can call it upper arm if you want. There was a confusion very recently, that's why. Okay, upper arm or arm, they are the same. Okay, there are no branches by the median nerve in the arm. Then when it comes to musculocutaneous nerve, you will wonder why there is C7. It's only C5 and C6. Biceps is C5 and C6. Brachial is C5 and C6. Then even the cutaneous supply is C6, not C7. But the C7 actually goes into coracobrachialis muscle. Okay, C7 goes into coracobrachialis muscle. That's why it's there. Then brachial plexus injuries. The first one, the abduction palsy, or in simple you call it Erb's palsy. Erb's palsy is due to traction on C5 and C6 nerve roots. Those are the upper 2 nerve roots, and damage to the C6 and C5 nerve roots. Now it can either be due to, in an adult, falling on the shoulder and the head like this, so that the two get separated out. You get traction on the upper roots. Then another possibility is that during delivery, complicated delivery, if you apply forces to deliver the baby while the shoulders are stuck inside in the birth canal, again the same thing can happen. Okay, there can be separation of the neck or the head and the shoulder. Okay, so that can actually give rise to bilateral Erb's palsy even. Okay, not unilateral, even bilateral. Okay. So remember this, upper roots, it's Erb's palsy, and this is the clinical picture. When the child is little large, you will see this deformity. You see this deformity, which is called waiter stiff position. Actually, it is called waiter stiff position. You, with the anatomy knowledge, you should be able to describe the anatomical basis of the waiter stiff position. Then not that people will go around and ask you to describe it, but then you will remember your anatomy better. Okay, that's why I ask you to describe it. Now, what is the deformity here? You have the shoulder adducted, and the limb therefore is by the side of the arm, elbow fully extended, forearm pronated. That's how you get the palm looking backwards here. Okay, so elbow, the shoulder adducted, and elbow extended, forearm pronated. So the reason is the C5 and C6 roots. If you remember the first few slides of this lecture, C5 and C6, it supplies almost all short muscles of the shoulder joint, including this deltoid, subscapularis, teres minor, then supraspinatus, infraspinatus. They are all supplied by, even teres major, all supplied by C5 and C6. All of them are gone. Therefore, the abductors of the shoulder joint here are actually gone, including deltoid. But the adductors, like pectoralis major and latissimus dorsi coming from behind, they are supplied by C6, C7, C8 roots like that. Okay, so they are not anyway C5 and C6. Therefore, adductors are kept unchecked by abductors. So you get the adduction of the shoulder joint. That's why the arm is hanging by the side. Okay, then you get the biceps and brachial is paralyzed. because of C5 and C6 gone. Biceps and brachial is paralyzed. So the triceps is C7 and C8. It's intact. So you get the extension of the elbow joint. Then the strong supinators are the brachialis, the biceps brachii, and supinator. Biceps brachii is supplied by C5 and C6. Supinator is supplied by C6. Again, both are gone. Therefore, and the pronators, pronator teres, pronator quadratus, they are supplied by C7, C8 like that. Okay. Therefore, it's pronator. Okay, that's why you get this beta tip position in this children. Then the other type of brachial plexus injury is the opposite, on the other end of the brachial plexus, Klumpke's palsy. You can get C8 and T1 roots damaged. Now, the opposite of that, if you get a breech delivery, when the shoulders are stuck inside, if you pull, you get the separation is at the lower end of the brachial plexus. Separation is at the lower end of brachial plexus. Okay. So the same thing can happen in an adult, falling from a height, suddenly hanging on to some object on the way. When the person is falling down, on the way, if it hangs on to some object, because of the speed and the weight of the person, you can get sudden pull on the lower roots of brachial plexus. C8 and T1 can get damaged, and the reason, the deformity is you get full claw hand. You get full claw hand here. You see all fingers are affected. Okay, full claw hand, because the intrinsic muscles of the hand are supplied by C8 and T1. So the intrinsic muscles of the hand are paralyzed because of the unopposed action of long flexors and extensors of the forearm and the anterior and posterior compartments of the forearm. You get a situation similar to this Walkman's ischemic contracture that I described. Because of the strong flexors, you flex the metacarpo, the interphalangeal joints. Extensors will extend the metacarpophalangeal joints. All lumbricus and interossei are gone in this case. Even the thenar and hypothenar muscles are gone, I think. Then, due to traction on the sympathetic chains here, you can actually damage the sympathetic chain upper part. You can get Horner's syndrome because you don't get sympathetic going into the head region from the superior cervical ganglia. So that's a different thing. Okay, associated with Klumpke's palsy, you can get Horner's syndrome. Few things about the axilla. What do you think? Do you need a short break, or shall I continue? You have an apex of the axilla which is formed by the lateral border of the first rib and the superior border of the scapula and the posterior border of the surface of the clavicle. So that is the apex. Then there is a little bit wide medial wall and a very narrow lateral wall, which is the bicipital groove of the humerus. Very narrow lateral wall. So the medial wall is formed by the ribs, intercostal muscles, and the serratus anterior muscle. The anterior wall is formed by the pectoralis major, pectoralis minor, and clavipectoral fascia. And the posterior wall is formed by the subscapularis muscle, teres major and latissimus dorsi muscles mainly. Okay, so that is your axilla. So the muscles that form it, actually you can go through it. Okay. Then the flow of the axilla is formed by, now you have the trunk here, you have the limb here, the fascia passing between the deep fascia of the trunk and the limb, and the deep fascia over the anterior and posterior axillary folds. You know that. Okay. So then you know this clavicle, clavipectoral fascia. Then you get the clavipectoral fascia here also. Then you get the pec minor here. Enclose the pec minor, you get the suspensory ligament of the axillary flow. This is the axillary flow that we described. Then branches of the axillary artery. The axillary artery is divided into 3 parts by the presence of the pectoralis minor muscle. First part has one branch, which is the superior thoracic artery. Second part has two branches, the thoracoacromial trunk and the lateral thoracic artery. Then the third part has three branches, two circumflex humeral arteries, anterior and posterior, and subscapular artery. And the extent of the axillary artery, is from the outer border of the first rib to the lower border of teres major muscle. Yes, teres major muscle. Then beyond that is the brachial artery. Beyond that, it is the brachial artery. Then the scapular anastomosis. Now the scapular anastomosis, it's the first part of the subclavian artery. Usually it's the first part of the subclavian artery. Anastomosis with the third part of the axillary artery. Now the first part of the subclavian artery, you get a trunk. Okay, I'll show you here. So first part, you get the thyrocervical trunk. Okay, this is the first part of the subclavian artery. The part medial to the scalenus anterior muscle is the first part. Part behind the scalenus anterior is second part. Part lateral to it is the third part. From the first part of the subclavian artery, you get vertebral artery, you get the internal thoracic or internal mammary artery, and the thyrocervical trunk. From the thyrocervical trunk, you get a branch called suprascapular artery, which is related to the suprascapular notch here. And from the suprascapular artery, you get branches supplying the supraspinatus and infraspinatus fossae. And you get, from the third part of the axillary artery, you get subscapular artery. A branch of that is the circumflex scapular artery, which also gives branches to the same infraspinatus fossa. So there will be anastomosis between these branches. Okay. Then there is a deep branch of the transverse cervical artery, okay, which is actually a branch of the thyrocervical trunk. Thyrocervical trunk again, okay, transverse cervical artery. A deep branch of the transverse cervical artery is related to the vertebral border of the scapula. That also anastomosis with the same circumflex scapular branch of the subscapular artery. So ultimately you get anastomosis between the first part of the subclavian artery and the third part of the axillary artery. So that is scapular anastomosis. If there is gradual obstruction to the proximal part of the axillary artery or the distal part of the subclavian artery, you can get collateral supply, supplying the upper limb and maintaining it. That's one thing. Then there is an extension to the scapular anastomosis, which is called acromial anastomosis. Okay, acromial anastomosis in that area of the acromion. So how that happens is you get branches from the suprascapular artery called acromial branches of the suprascapular artery. Okay, so you see the acromial branch of the suprascapular artery there. Then you get acromial branches of the thoracoacromial trunk from the second part of the axillary artery. If you remember the thoracoacromial trunk, it gives several branches. One type of branches are the acromial branches. Then you get acromial branches from the posterior circumflex humeral artery from again the third part of the axillary artery. So all these acromial branches from the suprascapular, thoracoacromial trunk and the posterior circumflex humeral, they anastomose and form another collateral supply circulation between the subclavian and the axillary artery. Now when you get the PDF of the lecture, you go through this slide, the thyrocervical trunk, the different names given. Okay, now the initial description is thyrocervical trunk from the first part of the subclavian has branches, suprascapular artery, transverse cervical artery, inferior thyroid artery. That is the typical description. Okay, then the transverse cervical artery has a deep branch and a superficial branch. Deep branch is the one that is related to the vertebral border of the scapula, so which we discussed in the scapular anastomosis. But some authors they use a different name. They use the term superficial cervical artery instead of transverse cervical artery. Okay, so when they use superficial cervical artery instead of transverse cervical artery, then they have to say the deep branch of the superficial cervical artery is the one that is involved in the scapular anastomosis. Okay, so that's it. Then there's another confusion, the dorsal scapular artery, the concept of dorsal scapular, because this deep branch is called dorsal scapular artery actually. Okay, dorsal scapular artery, which is involved in the scapular anastomosis. I didn't use it in my description purposefully because sometimes, usually you don't get an artery coming out from the third part of the subclavian artery. It usually is vacant, but sometimes you get an artery coming from the third part of the axillary artery. Okay, then when you have that branch, you don't have this branch, deep branch of the transverse cervical artery. Then this artery coming from the third part of the subclavian artery is called dorsal scapular artery. Okay, so that will replace this one. So that's why, in the initial description I said it's first or third parts of the subclavian artery. So these are, all different descriptions, but I can't make it any clearer to you. Okay, just go through it carefully when you get the lecture note. Okay, now this is Snell's clinical anatomy. That exact description is there. Here, instead of transverse cervical, he has used superficial cervical artery. Then this becomes the deep branch of the superficial cervical artery, which I called deep branch of the transverse cervical artery. Okay, it's a very simple issue. Okay. Okay, so the extension to the scapular anastomosis I already described. Go through it when you get the lecture note.